Hello, my name is Walid Brunjikji, and today I will discuss a case of spinal epidural arteriovenous fistula embolization. Our patient is a 59-year-old female who presented with a several-month history of progressive difficulty walking, urinary retention, occasional falls, and left leg numbness. Sagittal T2 weighted MRI demonstrated high signal in the conus as well as multiple flow voids along the dorsal and ventral aspect of the cord. On the axial MRI, you can see the high signal within the cord as well as the engorged vessels in the coronal venous plexus. Also, on the post-gadolinium MRI, you can see geographic areas of enhancement within the cord itself, consistent with a missing piece sign, which has been described in cases of congestive myelopathy. Selective angiography of the left L3 lumbar artery demonstrated a spinal epidural arteriovenous fistula with intradural venous drainage. Here in red we see the left L3 lumbar artery, and then in blue we see the left L3 radicular epidural artery. In purple we see the epidural arteriovenous fistula pouch, which is the site of the shunting, and then in darker purple we see the intradural draining vein. Here we see a more magnified projection showing the arteriovenous fistula in the epidural space. Our setup was relatively simple. We used a 5 French femoral sheath, a 5 French Michelson catheter, and then advanced an SL10 microcatheter over a synchro soft tip guide wire into the epidural fistula, and then embolized with Onyx 18. Here you can see our Michelson in the left L3 lumbar artery. Here we're carefully advancing the synchro micro guide wire into the left L3 radicular lumbar artery. Then you can see the SL10 microcatheter following over the wire and into the epidural arterial arcade. On the selective injection, you can see the epidural arteriovenous fistula and the network of epidural arteries going into the fistula. We then proceeded with the Onyx embolization. On the first injection, we were able to penetrate that arcade and then get into the venous pouch and achieve some filling of the proximal draining vein. For the remainder of the Onyx injection, we concentrated on filling the remainder of that epidural venous pouch, as well as embolizing any other arterial inflow into the venous pouch itself. We were able to remove the microcatheter, and on subsequent angiography of the left L3 lumbar artery, as well as lumbar arteries above and below the site of the fistula, we did not see any residual filling of the epidural arteriovenous fistula. Following the embolization, the patient had improved ambulation and sensation in the lower extremities and is still undergoing continued follow-up and improvement.